speakers. Dr. David Shprecher serves as Movement Disorders Director at Banner Sun Health Research Institute in Sun City, Arizona, and is Clinical Associate Professor with the University of Arizona, Phoenix. Prior to joining Banner Health in 2015, he started the Movement Disorders Clinical Trials, Tourette's Association of America Center of Excellence, and Huntington Disease Society of America Center of Excellence programs. Inspired by personal experience as an individual with Tourette syndrome, he has dedicated his career as a movement disorders neurologist to improving treatment options and quality of life for movement disorder patients. In addition to a long history of site investigator activities in movement disorder clinical trials, his observational research with Banner's Brain and Body Donation Program and the North American Prodromal Synucleinopathy Consortium is aimed at improving early diagnosis of and biomarkers for REM sleep behavior disorder, which is the strongest known clinical risk factor for Parkinson's disease and Lewy body dementia. Now I'd like to introduce Dr. Evidente. Dr. Evidente is the current director of Movement Disorders Center of Arizona in Scottsdale. Dr. Evidente is a fellow of the American Academy of Neurology and a member of the Movement Disorder Society. He is a frequent presenter and invited lecturer at national and international conferences and symposia. Dr. Evidente has also served as a principal investigator and co-investigator for numerous clinical trials regarding treatments for Parkinson's disease and other movement disorders. Now I'll turn things over to Dr. Shprecher. When his presentation is completed, Dr. Evidente will join for questions and answer portion of this webinar. Dr. Shprecher, please take it forward.
The most commonly quoted statement of 2020 and going into 2021 is, "You're on mute." And I pulled one myself. Thank you all for having me. I want to thank the organizers and Dr. Evidente for inviting me today to speak to you about this topic of atypical Parkinsonism. Many people often are told, you have Parkinsonism, but we're not sure it's Parkinson's disease. So I want to take some time tonight to try and help you understand what we mean when we just bring this topic up and how we as the neurologists will come to a diagnosis of atypical Parkinsonism and sometimes end up with something else. So the first term, Parkinsonism, is what we're going to start with. So I'm just going to kind of help you understand what we mean as doctors when we use that term. And then what are the conditions that fall into that realm of atypical Parkinsonism, and how do we diagnose those? Also, we'll touch on what to expect with some of the more common types. Again, there's a broad topic, so it won't be possible to cover every single type, but there'll be some ample time for question and answer. So the most important symptom that makes us think about Parkinsonism is when you have that slowness of movement. That's not just that you're moving a little bit more tired at the end of the day, you're shuffling now and then, but those repetitive movements that we do throughout our day get smaller and smaller as we repeat them. For example, your handwriting gets smaller as you go along the page. Your arm doesn't swing, or your arms don't swing quite as much as you continue walking. That's what we mean by the bradykinesia. And that's the most important symptom that we're looking for in Parkinsonism, that slowness of movement. We're usually looking for at least one of these other features for us as neurologists to say that you have Parkinsonism. This can include tremor, but usually when we're thinking about Parkinsonism, we're looking for tremor that's worse when the arm or leg is fully supported at rest. Usually gets better with activity. We're also looking for muscle stiffness, what we call medical terms rigidity. And it's something that you may experience as a tightness or actual discomfort. But on the exam, when we move the arms or legs around, even the head back and forth, side to side, we feel resistance. And it actually gets worse when we do things to distract you, like making circles in the air or opening the hand open and closed. The other feature that's less common in Parkinson's disease, but still a feature of Parkinsonism, is a balance problem where it's hard to catch yourself when you lose your footing. And if you've ever seen a movement disorder specialist like me or Dr. Evidente, you know we often will kind of have you stand up and pull you backwards and see if you can catch yourself with a step or two backwards. That's looking for that postural reflex. And that's often lost in someone with Parkinsonism. So overall, we're looking for at least 2 out of these 4 features to say that you have Parkinsonism. But then when we see the Parkinsonism, the first question is this caused by a degeneration in the brain or something else? And so we want to review your medication list carefully and think about whether you've been exposed to some of the antipsychotic medications or nausea medications that can cause Parkinsonism. We also may ask about occupational history, particularly if you had done a lot of welding in the past, which can cause Parkinsonism from deposits of the manganese fumes if you didn't wear your respirator. But if we don't have any other alternative explanations and you have very clear-cut Parkinsonism, then we start looking at the story. We're looking for the features, how everything played out, what other symptoms came along with the Parkinsonism, and which features came first. In particular, we're often asking about whether you have been told or thought yourself that you act out your dreams, because only certain causes of degeneration in the brain seem to be associated with acting out of the dreams, which can come sometimes years before any of the other features are diagnosed. Also common, mainly with Parkinson's disease, is a change in the sense of smell. Many people tell me they've never had a good sense of smell. And then constipation issues that can be present for many, many years before it's diagnosed. Now, as we get more experience and comfortable with the exam, many of us as specialists may only order the brain scans in cases where things aren't quite adding up. So if someone presents to me with a very classic Parkinson's disease, and there are no other features suggesting there's something else going on, I don't necessarily put them through extensive battery of tests and brain scans, particularly if they have limited insurance where there's going to be a lot of out-of-pocket costs that are not necessary. However, there are select cases where the DAT scan and also other types of brain scans can be useful. So the DAT scan takes a picture of the nerve endings in your brain where those dopamine cells project to and release dopamine. You can see on the left here what it should look like is a normal kind of comma-shaped appearance to those nerve endings that project to the motor areas of the brain we call the basal ganglia. On the right, you can see that shape is lost. And so that tells us there's been damage to those nerve endings. So it's a common pitfall is many doctors, even radiologists, will say that this test shows Parkinson's disease or is consistent with Parkinson's disease. And that's a little bit overly simplistic. What it does is it shows evidence to help support that there's a neurodegenerative cause of that Parkinsonism that we were talking about before. So the astute movement disorder neurologist will explain it this way, that now that we've done this scan, that tremor that we saw, we weren't sure what type of tremor you have, does look like, because it looks this way on the right, like it's due to degeneration in the brain. And now we have to decide if that degeneration is from Parkinson's or atypical Parkinsonism. So that's really on us to get the whole story and do the right kind of exam. That's the most common reason to order this test, and it's what it's approved for, is if someone has tremor that's there with activity, not just at rest. So it could be a little of both, or if you start with essential tremors, which is mainly there with activity, but then you develop a lot of rest tremor, it can be hard to tell if you really have the bradykinesia because the tremor interrupts the movements. And so that scan can be very useful to look for evidence of degeneration in the brain. It's sometimes useful also if someone's taking an antipsychotic medicine for, sometimes not just for hallucinations, but actually for depression. And that medication blocks dopamine receptors. So if the Parkinsonism develops after you've been taking that medicine for a time, we may need this scan to help us decide if we need to talk to your psychiatrist about switching or not. Because obviously if you had degeneration in the brain and loss of dopamine nerve endings that blocks dopamine activity, antipsychotic could make that much worse. And so it's a tough conversation to have with a psychiatrist to have to change that around if it's working well for you. This scan can be very useful in those circumstances. Now, the other important thing that we look for to help us decide, do we need an MRI, besides just doing a thorough exam and looking for abnormal reflexes or other things that make us worry about, say, a tumor or a stroke, we're also thinking about whether the Parkinsonism is restricted just to the lower body. Because if just your legs have a problem and you feel like you're stuck in place when you try to walk, or you shuffle when you walk, but your arms are working fine and there's no tremors, that might not necessarily be neurodegenerative Parkinsonism. And the DAT scan may not be necessary because we're already going to have our answer when we do the MRI or the CAT scan. And so the two main things we're looking for with that lower body Parkinsonism are normal pressure hydrocephalus and vascular Parkinsonism. So here's an example of what we're looking for with normal pressure hydrocephalus, or NPH for short. This is your brain. This is the front of your brain, just above the eyeballs. And this is right in the center, so we're looking across the brain, is these chambers in the brain that hold the spinal fluid, we call the ventricles. They're much bigger than they should be, and yet your brain, the brain of this individual here, doesn't really seem that shrunk. So those chambers will look large if the brain has shrunk because of degeneration in the brain or aging. But if these are enlarged out of proportion, and we'll actually measure to determine if it's out of proportion, large enough to cause symptoms of difficulty walking, that's where we say this could be normal pressure hydrocephalus. And what that is there's a problem absorbing the fluid, so it's not draining properly. And these areas around the ventricles are where the fibers are that supply your legs. And so if it's pressing on those fibers, it makes the signal hard to get down to the legs. And you may get kind of shuffling and unsteadiness when you walk. It almost looks, when we examine the person, it looks almost like a magnetic gait, like they're walking in metal boots on a magnet. So if someone has normal pressure hydrocephalus, placement of a shunt by a neurosurgeon where they put a little tube in here and then connect it to another part of the body, like the abdomen or the chest, that ventricular shunt can resolve the problem with walking. It may also potentially improve other symptoms of mild cognitive impairment, so trouble concentrating, trouble coming up with words, remembering things, and also bladder urgency. So if someone has advanced dementia, it won't reverse that because that's usually from a combination of degeneration, not just normal pressure hydrocephalus. But if the main problem is trouble walking, it could help. And how do we determine if you're likely to benefit from the shunt? Is we have to do a spinal tap procedure where we remove the spinal fluid, at least 30 milliliters of spinal fluid, and then see if there's an improvement in your walking afterwards. So a common pitfall is somebody will get sent and have this procedure, but then they'll just ask you, did your walking get better? And really, that's not a great way to measure it. So here's how we do it in the movement disorder clinic is we'll actually have somebody and we'll do a timed walk So this is the woman whose scan I just showed you. And you can see she walks like her feet are glued to the floor almost. So that magnetic gait is what we call it in the chart. And then I had a colleague who does a lot of spinal taps go ahead and remove at least 30 milliliters of fluid, and that'll take several hours to replenish. So we got to do this right afterwards. We'll go ahead and we'll repeat the tap. And you can see here, we've got people there for safety, but she's definitely walking a lot faster. And we actually do a timed walk, same distance, and measure that. So this is someone that actually benefited from from not just from the spinal tap, but actually from the ventricular shunt. And she didn't have any other slowness, stiffness in her arms that would point to something else. Unfortunately, many people can have more than one thing going on. And so people with normal pressure hydrocephalus may also have symptoms of Parkinson's disease. So tremors, for example, they may still need treatment for Parkinson's as well. And they also may have what we call the vascular Parkinsonism. So you can see on the MRI of this person, these bright areas are areas where there's a material called myelin that insulates connections between cells in the brain. We call axons, but they're really like telephone cables. So you remember back in the 80s, if there was a problem with the telephone cables, you get a scratchy phone connection. Well, here they get a scratchy connection if that myelin is worn off those connections, off the cables. And so it's, again, hard to get the signal down to the legs. And you can see a more dramatic example higher up in the brain. These are the fibers that supply the legs, and they're all worn down. We call this vascular Parkinsonism because they're very small blood vessels supplying those fibers. And so people who are genetically predisposed, especially if they've had high blood pressure in middle age, it's not well controlled, or a history of smoking, or both, they're much more prone to this problem. And this can cause really severe Parkinsonism. You can see this gentleman can barely get out of a chair without help and barely walk. And that was his MRI that I just showed you.
Hands with a belt make a great spotting tool. Just try to stand in place, show me what happens if your legs start to bounce on you. Right.
So really trouble getting those feet to go, and also unsteady on his feet. Unfortunately, the vascular Parkinsonism, if you don't also have Parkinson's disease as a factor, doesn't respond to the Parkinson's medications because it doesn't really improve the ability of that signal to get through to the feet. It's not due to low dopamine in the brain. Now, this is something that is really important for all of you to hear. If you have Parkinson's disease, or you're being considered for a Parkinson's diagnosis, and your doctor is saying that they think you might have atypical Parkinsonism because you can't take levodopa. Now, one of the main features of the conditions I'm going to talk to you about next, the atypical Parkinsonism, where there's degeneration in the brain, is poor or waning response over time to levodopa. That doesn't necessarily mean intolerance to levodopa. There's a difference. If you take levodopa and you take even very low doses, but it just makes you really sick, that may mean that your body does a really good job of converting that levodopa to dopamine while it's still in your digestive tract where it can cause nausea. The reason carbidopa is in there to prevent the body from converting it too soon to dopamine where it can cause nausea in the gut, or dizziness if it's still in the bloodstream. So one approach we'll often use is we'll just start you with very low doses, like half or quarter tablets once a day, and then work up to twice a day in a week or two, and then 3 times a day after that. But we'll work your way up much more gradually. If that doesn't work, we still got other tricks up our sleeve. We may, if you can afford it and your insurance agrees to cover it at an affordable price, give you carbidopa 25 milligram tablets with each dose, which may help prevent that side effect better than the amount that's in the pills. Unfortunately, most insurance doesn't cover it well, and it can cost hundreds of dollars a month. So we sometimes will have to try and find a nausea drug that won't block dopamine in your brain, and there are very few options that actually work well in this situation. One of them, there's a national shortage. It's called Tygan, or trimethylbenzamide. there's another one that in all the other developed countries of the world is well widely available, except the United States, called domperidone. But we don't yet have it approved here in the United States. And so we sometimes have to order it from Canada in order to help someone tolerate their levodopa. But don't let someone tell you that you have atypical Parkinsonism unless they've tried all of these tricks. And if they don't know what you're talking about when you bring this up, please get a second opinion with a movement disorder specialist. Another important problem, some people, after they take their carbidopa levodopa, they have this brain fog, or they just fall asleep when the medicine starts to kick in, because the immediate release tablets kick in really fast for them. They do a really good job of absorbing the medication. And that has to do with getting it to your brain too quickly. And so we may switch you to a slow release tablet if that happens. And that often mitigates or gets rid of that problem. So again, if your doctor doesn't know what you're talking about when you bring this up, they're probably still familiar with the slow release pills. So you might want to talk to them about giving it a try. Don't try and do any of this stuff on your own, but talk to your doctors and take home the information that you're getting today and see if it's relevant to you after talking with your healthcare professional. So the important thing when we're seeing that things aren't quite adding up is we're asking for other clues that might point away from run-of-the-mill Parkinson's disease. One of the most important features would be if you're not responding well to Parkinson's medications, even though we've taken measures to help you tolerate levodopa. The other would be is if there's early severe impairment in memory and thinking, enough to interfere with everyday activities. If there's very early problems with hallucinations, if there's dramatic fluctuations in level of attention and disorientation, that might make us think about dementia with Lewy bodies. If there are very serious falls that are unprovoked, not just because your pets ran in front of you or you couldn't figure out who's walking whom, but you actually fell just because you lost your balance and it's happening on a regular basis, if that happens in your very first 3 years, that's a big red flag. It could be one of the atypical disorders. Also, if you have trouble moving your eyes in the vertical direction, that's also not typical early in the course of Parkinson's disease. Early severe problems with a drop in blood pressure when you're standing up is not typical for Parkinson's either, unless you're taking lots and lots of blood pressure lowering medicine. Sometimes we have to back those down and see if that problem is still present. And if it is in your first 3 years, that's another red flag that makes us think, wow, this could be atypical Parkinsonism. And these are the common reasons where a general neurologist with a lot of experience with Parkinson's disease may consult the movement disorder specialist, is to sort out these unusual cases. So, I put together kind of a table here just to give you a sense of all the different things we're looking at and what are the conditions that are most likely to cause what. And one thing I want to kind of bring back to you is I mentioned REM sleep behavior disorder earlier. That's where in the middle of the night when you're having an action-packed dream, you may act it out. You may jump out of bed, hit your bed partner, strangle your pets, because you're dreaming that you're protecting them from an intruder, but you're actually attacking the person next to you. And that is REM sleep behavior disorder. And that happens on a recurrent basis in Parkinson's disease, but also in multiple system atrophy or dementia with Lewy bodies. It's very unusual in these other conditions, though it rarely can occur in a subtype of progressive supranuclear palsy. One thing we don't have is we don't have a way to actually take a picture of the brain and see what are the deposits that are causing your symptoms. The only scans we have available right now, they mainly look for the deposits that cause Alzheimer's disease, like amyloid plaques. But we don't have a scan to look for the Lewy bodies of Parkinson's and dementia with Lewy bodies, or the other deposits that these other conditions have. So that's where, brain donation, and we have a brain bank that we work on with Mayo Clinic over at Banner. Anyone can sign up that's in Maricopa County. Signing up to donate your brain will help people down the road by helping us learn how to develop these tests. It will also give your family a definite diagnosis which condition you had, because the symptoms I'm telling you about tonight aren't fully diagnostic. They're just clues that, if you have all the main features, make us fairly confident this is what you have. But it's never 100% without seeing the brain under a microscope. Now, the term Lewy body dementia is a term we use to make it clear that the problem with memory and thinking is related to Lewy bodies that are deposited in the brain. But it can be in advanced stages of Parkinson's, you have dementia, or it could be if you have dementia in your very first year of symptoms. But that type where the dementia is present very early, we actually call dementia with Lewy bodies. And that one has some other features. First of all, there may be profound fluctuations in your level of attentiveness or alertness. The Parkinsonism is a core feature. Not everyone has that with dementia with Lewy bodies. Recurrent visual hallucinations, and then the recurrent dream enactment. And so if you have at least 2 out of these 4, that makes us very confident that this is dementia with Lewy bodies. If you don't, then the DAT scan may be useful, particularly if you don't have very clear-cut Parkinsonism. And having that DAT scan is another important clue. Also, if we're not sure if you have REM sleep behavior disorder, a sleep study looking for specific features of REM sleep behavior disorder can be useful, but only if it's done by a neurologist that understands what the doctor's looking for, because most sleep doctors won't comment about the things that we're looking for. So it's important that if you have Lewy body dementia, either from Parkinson's or dementia with Lewy bodies, that we really avoid most antipsychotics for hallucinations. Even though doctors often prescribe olanzapine if someone's really out of control, we won't want to use that long term because it can really worsen motor symptoms of Parkinsonism. We usually will use the quetiapine or the prescription that's FDA approved is Nuplacid, known as pimavanserin, because quetiapine or Seroquel and Nuplacid are less likely. They don't really show evidence at the doses we commonly use that they don't worsen Parkinsonism. So Nuplacid doesn't worsen it at all. Seroquel at the doses we commonly used does not worsen Parkinsonism, and it's less likely even at higher doses. Now, for those of you who are old enough to remember, this actor was starring alongside Bo Derek in the movie 10, but he also played an alcoholic millionaire in the movie Arthur. So I wasn't allowed to stay up to watch this movie when it first came out, but the new version of Arthur that was actually about the alcoholic billionaire. So Dudley Moore played the original. This is Dudley Moore when he was first starting to have some symptoms of his illness, where he was forgetting his lines, and Barbra Streisand had to let him go from the set of The Mirror Has Two Faces. And here he is much later in life as he's developing neurological symptoms. You can see when the Queen actually made him a knight, he wasn't able to show how elated he was because he was having these muscle spasms in his face. And this is because he actually was being diagnosed with progressive supranuclear palsy. He never lost a sense of humor, though. Since it's a very rare disease, he thought it was really magnanimous of him, since it only affects 1 out of 100,000 people, that he accepted this fate for himself and protected the other nearly 100,000 members of the Screen Actors Guild from this fate. Now, PSP is something that usually causes early severe falls, but it also impairs the ability to move your eyes up and down, so to look vertically, and it causes atypical Parkinsonism. Later in the course can cause swallowing problems, but even early on can cause a frontotemporal type dementia, where there are problems with language, and some people even get very impulsive. This is an example of someone with PSP. You can hear it has a kind of a gravelly pronunciation problem with his speech and trouble moving his eyes up and down and severe balance problems.
Yes, I fall. How often do you fall? Every day. Did you trip on something, or is there something that makes you fall? No, I just fall. Just lose my balance and fall. And you don't dot there. You follow it with your eyes.
So you can still look side to side, but then we have him try and look up and down. And it just can't do it. And some people, they're slower in their eye movements up and down, but they can still do them to some degree. We also on the MRI can see specific features with PSP, and there's a thinning in this part we call the midbrain that we're looking for on the MRI. So the MRI is also useful if we're looking for specific features of an atypical Parkinsonian disorder. There's another condition that can cause a different appearance. There's something that looks like a plus sign we call the hot cross bun sign, and then there's also this atrophy in the part of the brainstem called the pons. This is a condition called MSA for short, multiple system atrophy. And with this condition, there's usually an early problem either with autonomic nervous system or with the coordination center of the brain, the cerebellum. And so if somebody, even though we take away medicines that might be contributing, they're having severe drops in blood pressure when they stand up, and their Parkinson medications aren't working as well as we'd expect, or they're losing benefit, then we would diagnose multiple system atrophy. We would also do so if we saw they mainly had severe coordination and balance problems. One important clue is we're also looking not just for drops in blood pressure, but also for bladder incontinence. So with atypical Parkinsonism, it is a more rapid progression than what we typically see with Parkinson's disease. So this is an important diagnosis for us to be upfront about when we're considering it, because people aren't always prepared for this rapid progression. Most people with these atypical Parkinsonisms become wheelchair bound because of their gait and balance problems within the first 3 to 5 years. This is the average. There are people that break the rules. And on average, they live 7 to 8 years from when the symptoms start. We've met many people with Parkinson's who are still alive 20 years after they were diagnosed and going strong. That doesn't happen with the atypical disorders. There are rule breakers that still live past 10 years, but it's rare. And there are people that even progress much faster. And some people do respond to the levodopa somewhat, but they may require much higher doses, and the response may really decrease, wane over time. So it's important that we still ask about all the other symptoms that could have treatments, like sleep problems, mood and anxiety problems, bladder control issues. Even constipation is an important symptom to ask about and to address. And one of the most important things you can do if you're being considered for a diagnosis, not just of Parkinson's disease, but atypical Parkinsonism, is to make sure that you've got all of your care team coordinating your care together, and they're copying each other in on their reports. They're communicating if they think medications need to be changed. And very often we'll have a cardiologist involved in people with the autonomic problems, or urologist as well. And we'll have physical therapy, speech therapy, occupational therapy, and social workers involved to give you the therapies that you need at each stage of the illness, but also to help you plan ahead, especially with social worker, so that you're prepared for each stage and you're able to cope with things as they come up and not being reactive, and instead can be proactive. So that in a nutshell is how we approach atypical Parkinsonism. Really appreciate your attention and your having me tonight. I'm going to discontinue the screen share now, and then we're going to go through some of the questions and answers.
Hey, David, that was really excellent. This is Jerry.
Good evening.
Hey. Yeah, wonderful. That was really comprehensive, concise, and straight to the point, and very understandable. I'm going to start off with a few questions that my patients have actually submitted to me, both in my clinic and online, about the topic that we are tackling today. And one of the more common questions I was asked was, how do you differentiate essential tremor that first developed when they were younger, and then as they got older, now they're in their 60s or 70s, they developed some rest tremor, maybe some shuffling gait, maybe some stoopness of posture, and then the primary care doctor says, well, you're just getting old, right? So how do you approach such patients, especially so if they start developing this symptoms of Parkinsonism and that the drugs they use for essential tremor are just not sufficient?
unmute myself this time. So it's a common question that we get. We often see people that have had essential tremor already. And just to clarify, again, essential tremor means the tremor is there more when you're holding your hands out or when you're doing things with your hands, like reaching out finger to nose, but better at rest than it is with activity, and been present for at least 5 years. So if someone clearly has essential tremor, it's been there for at least 5 years. And the example we just heard, 20 years or more. And they start to have some rest tremors. That actually can be seen with Parkinson's disease, but essential tremor over time does develop a resting component, okay? What we don't usually see is a very severe resting tremor in the legs, for example. So if the leg is going up and down by itself, even just sitting flat, feet flat on the ground in a chair, that's a big red flag. There's something more going on. But oftentimes it's hard to sort out because the tremor at rest isn't as bad as the tremor with activity, but it's definitely worse than before. And it's much worse on one side than another. Essential tremor is usually more symmetric, and usually more similar on both sides than what we see with Parkinson's. And as we get older, it's true, we may stoop and we may shuffle for other reasons than just Parkinson's. So this is an example where the DAT scan can be useful. So I don't order it in every case. And I have a lot of cases where I'll even make fun of my colleagues for ordering it because it's so obvious that this is Parkinson's disease, but this is not one of them. This is one where they're shaking so much, I'm trying to decide they have that bradykinesia, and I really can't tell for sure. And that's hard to sort out, and the DAT scan may be very useful. One other thing I'll tell people, some people say, well, why do I have to do a scan? Can't you just try some treatment? And it's true, we can do a treatment trial with carbidopa-levodopa, but as I mentioned earlier, some people may have tolerability issues, and not everyone's Parkinson's tremor responds just to one medication. They may require a combination of several meds that require careful monitoring for side effects. So before we go on that whole odyssey of trying all different drugs, I'll often encourage people to go through the trouble of the DAT scan first.
Yeah, I agree with every point that you made with your explanation. And with the distribution of the tremor, though, suggests more ET versus PD or the other way around. Like, for instance, a jaw tremor or a yes head tremor or a no head tremor or a leg tremor. Do any of this tremor, or a voice tremor for that matter, would the distribution or area involvement of the tremor be suggestive of, one versus the other? Yeah,
so if someone's already had essential tremor for a long time, it's very common to see head and voice tremor as well. But when we're first diagnosing someone, it's more common, especially in an older onset patient. And now that I'm approaching 50, older to me is 50 and over. But we generally define young onset below age 50. Some young onset patients are more likely to have a little head tremor. But another important feature is if someone has prominent rest tremor in the legs, they're sitting in a chair and that leg is shaken on its own, fully supported at rest, especially if it's unilateral, that's generally not essential tremor. So that's another important feature, is if it's rest tremor, prominent rest tremor in the lower body.
Yeah, I just want to add that I think in my experience, the jaw tremor as well is just statistically more common in Parkinson's patients than it is
well, actually, there's an update on that. We haven't published the paper yet, but the Brain Bank crew is working on a study to compare people who are diagnosed based on the autopsy who were followed with jaw tremor, and all the specialists in the group saw as jaw tremor, and they kind of put their nickel down what it is. And it actually did not predict the diagnosis. And we have to publish the paper, but so far that's what the paper's likely to come out after all the peers review it. So it may be that even though we think in our experience jaw tremor is more common in one versus the other, the autopsy research, and at least in Maricopa County, doesn't bear that out. Yeah. And the other caveat I want to add to that is that sometimes I see patients also with asymmetric essential tremor. In other words, although conventional teaching tells us that Parkinson's is more likely to be asymmetric and essential tremor is more likely to be symmetric, sometimes I see patients with Parkinson's with symmetric symptoms, and I see sometimes, patients with essential tremor Yeah.
with very asymmetric, sometimes even just one-sided symptoms. So if you have it becomes very confusing, for instance, for somebody to have started with a postural and action tremor of one hand, and then down the road develop, some rest tremor of that hand. And the question is this Parkinson's, or is this just, chronic essential tremor, which is asymmetric in presentation?
Can I give you another quote? So I already told you the quote of the year is "You're on mute" for last year. But the quote I want you to take home from me, this is what I always tell people is patients don't read the textbooks.
Right.
And so we're taught that essential tremor is more often similar on both sides, but actually at least a third of cases that's not true. And vice versa, there are people with Parkinson's that still can have symptoms on both sides at the outset. So yeah, it's another clue that we look for, but we have to kind of look at the whole big picture and not just that one aspect. Yeah.
And then in terms of levodopa responsiveness, I do start some patients in the absence of a DAT scan. Whenever I see these patients of an overlap between ET and PD, I'm not really sure if this is just pure chronic ET versus ET and PD. Sometimes the response to levodopa can not necessarily predict that they have developed Parkinson's as well, especially if they've developed tremor predominant Parkinson's. And usually the clue to that is that these patients now have very severe both rest and action tremors, which more often than not is asymmetric. You give them some levodopa and keep increasing the dose, and then patients, don't respond. And then you do a DAT scan, and lo and behold, you see, the DAT scan abnormalities that seem to suggest that the patient has overlapping Parkinson's. What about orthostatic tremor? Do you see orthostatic tremor, which is, for the audience, tremor of the legs when you're standing in place, not when you're walking, not when you're seated, but when you're standing in place? This orthostatic tremor of the legs while standing, does it suggest one diagnosis versus the other?
Yeah, we definitely see that in all of our movement disorder clinics, and it is something that can be present with some of these other conditions. I've definitely met quite a few people with orthostatic tremor that also have essential tremor of the hands. It's challenging to treat, and then we also have to sort it out. There's all these different kind of medicalese, orthostatic tremor and orthostatic myoclonus. I know some of my colleagues at Mayo Clinic have suggested that primidone, which we use for essential tremor, can also help with the orthostatic tremor. It's more of a myoclonus. But it's tricky because the medications for orthostatic tremor don't seem to be as effective as often as somebody with essential tremor taking essential tremor drugs. Gabapentin, clonazepam are the main two if something's going to help. I don't know if you've seen any others.
Yeah, I agree. And what can be pretty confusing at times also is when a Parkinson's patient develops an orthostatic tremor. And the question is whether the orthostatic tremor is part of the Parkinson's syndrome or Parkinson's disease, or is this a manifestation of essential tremor? And I've actually done neurophysiology studies on such patients, and the frequency will actually help determine whether patient has an overlapping essential tremor manifesting as orthostatic tremor. So the classic orthostatic tremor is about 13 hertz and above, so 13 beats per second. It's really, really fast. It's usually symmetric, whereas the orthostatic tremor that we see in Parkinson's disease and the atypical Parkinsonism is much slower than that. So very rarely is the frequency more than 10 hertz. And very frequently, the orthostatic tremor in this Parkinson's syndromes is kind of asymmetric. And the kicker is some of these patients with Parkinson's disease or atypical Parkinsonism, slow orthostatic tremor, that's a term they use now, slow orthostatic tremor have actually been levodopa responsive. And we don't usually think of levodopa as a drug that we use for orthostatic tremor, but apparently in the Parkinson's population, it's something to think about. I wonder whether you've seen such cases yourself.
I have seen cases where the tremor is mainly in one leg, and that always makes me worried, that this could eventually turn out to be more of a Parkinson's type tremor. But if they don't have any other features yet, sometimes you have to wait and see how things evolve.
Yeah. And then what about the DAT scan? You know, I and many other movement disorders specialists I've spoken to over the years have sworn that we have followed patients that look like they have Parkinson's. They're levodopa responsive long term, and yet these patients have quote unquote normal DAT scans.
Mm-hmm.
Are you one of those believers in you know in this?
Yeah, unfortunately, there's kind of a fly in the ointment there. So,
Yeah.
you know, there were studies where they're reviewed by, you know, international experts, you know, eyeballing the scan and saying if it's normal or not, where, you know, these world leaders like Tony Lang say, you know, when they look at the videos, they can see that why this is the case, that this person has a different type of tremor. We call it dystonic tremor.
Sure.
You know, so there are all these features. But when I moved to the Phoenix Valley, what I found is the quality of the scans and the interpretations varies quite widely throughout the state. And so I have very little trust in not only in the interpretation, but even in whether I'm going to get a good quality image. So it's just another piece of information. And so I always have to see the scan, see if the images look the way they're supposed to, and not just trust what the radiologist said.
Absolutely. Yeah, I do the same thing. I always insist that the patients, you know, ask for a copy of the CD just in case my office doesn't receive a copy of the CD. Or sometimes I've actually asked for a back door directly from these radiology places so that if I don't receive the CD, I just, you know, go online and check out the DAT scan images myself.
Can't emphasize that enough for the audience. It's really
absolutely,
important
absolutely.
to see the pictures.
I guess the take-home message is that normal DAT scan is not always normal, right? It really depends on who's reading these films, and that, as you just said, there might be a disagreement, a discordance among different readers, and that brings me to my second question which is not all of these DAT scanners quantify the signal, right? There's a software that they use called the DAT Quant or DAT quantification. And unfortunately, not every scanner or scanning facility has this software. And I tend to trust more those that did that quantification versus those that don't.
Yeah, I think it's useful information. You know, when the scan was approved, it was approved based on the visual inspection, but it's another important tool that's available only at select centers. But I've also seen cases where someone has the whole history and everything, the way everything adds up, it still didn't fit in with Parkinson's to begin with. And only based on that software alone was there a subtle abnormality. Sure. In that case, the software isn't enough to make the diagnosis. We still have to look at the whole picture. Yeah,
and in fact, you know, for many of these films that I have disagreed with, I mean, they're not floridly abnormal, to be honest. They're just what I call asymmetric. So one side seems to be a little less bright than the other side, maybe either the caudate, which is the head, or the putamen, which is the tail of that comma or that bean-shaped structure that you showed us. And the question is, you know, when the radiologist reads this and there's a little bit of asymmetry, a little, you know, less formed, you know, comma in one side of the brain versus the other, many of them read this as normal, and yet when I see a patient, and it kind of correlates with, you know, their symptoms are in one side, which correlates with the opposite side where the signal seems to be reduced. I kind of say, well, in the absence of that quantification, I think you might have early Parkinson's disease, and that most likely I'll try on some Parkinson's medication. And these are the patients that I actually bring back maybe a year or two after, for sure, and we'll probably do another DAT scan at that point to see whether there has been an evolution of this one.
I think this is really eye-opener for people, though. The take-home point also is the DAT scan is not a yes/no answer. You know,
absolutely.
Do you have Parkinson's or not? And it's just another piece of information whether there's that neurodegenerative cause of the Parkinsonism.
Okay, there's a question as how many facilities offer the DAT scan? You want to answer that, David?
Well, I mean, when I worked at the University of Utah, they were the only one in the state, and you know, the guy that was running the program had developed the scan, so I always knew what I was getting. Here, I've lost track. There's just so many new places popping up all over the place here. There must be dozens in the state of Arizona offering it.
Yeah, and without wanting to publicize one over the other, I've actually had best experience in terms of quality of scans, at least locally, here in Arizona with the SMILE facilities. They just have the best scanners, the best quality. They also have in some facilities the DAT one. And what I like about their scans is that they actually give you a summary picture of the different slices or cuts, and which instead of giving you this individual cuts and you're not really sure whether you're really interpreting, it's like smack in the middle of the structure.
I've never had a patient see me for consultation where I already got the disc from SMILE before the consult. So please, if you have it done there and you're seeing someone that doesn't have a way to log in the system, make sure you have it on a disc.
Absolutely. But you know what? SMILE is one of those facilities, though, that you can ask for a backdoor very easily, too.
Oh, yeah, we're going to look into that.
Absolutely. And then just as a follow-up, there's actually more than one study now where they looked at these DAT scans at one point where they were interpreted as normal, and yet these patients had, had Parkinson's clinically and were levodopa responsive. And true enough, some of this, I forget what the percentage is, but a good percentage of these patients actually, a year or two after, had floridly abnormal DAT scans, which comes to show that, again, a normal DAT scan at the get-go, especially in the early stages of Parkinson's, may be misinterpreted as
true.
As being normal.
Yeah, definitely in Arizona.
Absolutely. And then what about the atypical Parkinsonism syndromes? In your experience, which of those can present with abnormal DAT scans, and therefore the DAT scan doesn't necessarily mean it's Parkinson's disease?
Well, all of them that are due to damage to the dopamine system, by definition, may have an abnormal DAT scan. The first two I talked about, where it's just the lower body involved, normal pressure hydrocephalus and vascular Parkinsonism, should not have an abnormal DAT scan. The other types may, however, depending on where most of the changes in degeneration in the brain are, they may or may not. And particularly with dementia with Lewy bodies, especially if the person doesn't have classic Parkinsonism, they mainly just have the other features. It could be the DAT scan could be interpreted as normal, and correctly so. Also, corticobasal degeneration is a rare type I didn't talk about that also can have a normal appearing DAT scan. So it's just another piece of information that helps us kind of narrow things down. But just looking at another important thing I've clarified, looking at the DAT scan, it gives us some clues if it's very symmetric and both sides are degenerated equally. It makes us think more about atypical, especially if it's early in the course, because usually even the scan itself is worse on one side than the other early in the course of run-of-the-mill Parkinson's. But that's just another clue. Again, patients don't read the textbook.
Absolutely. And I just want to re-echo what you said earlier on. I think the best utility for the DAT scan is differentiating pure essential tremor from somebody with Parkinson's disease, especially if that patient with essential tremor has a resting component or has some subtle Parkinsonism. And I think the other, I agree with you as well. I think the other population of patients where I find the DAT scan to be very useful would be patients with drug-induced Parkinsonism versus Parkinson's disease. And when you're dealing with elderly patients in their 60s, 70s, or 80s, and they're given us a dopamine blocker, whether it be for psychiatric reasons or for nausea, or for migraines and so on and so forth, some of these patients may develop drug-induced Parkinsonism. And mind you, I've seen drug-induced Parkinsonism, which is asymmetric. And you do a DAT scan, right? Because you think it's Parkinson's, and yet the DAT scan is perfectly normal. And how do you know it's drug-induced? Because you stop the drug, right? You stop the drug, and the so-called asymmetric Parkinsonism reverses.
It can be tricky because drug-induced Parkinsonism can take sometimes months, even up to a year, to completely clear up. We're not sure why, but this is well described.
Well, they've always spoken of an entity called tardive Parkinsonism. So we usually think of tardive dyskinesia. So for patients taking strong antipsychotic drugs or strong D2 blockers, whether it be for psychosis or depression or bipolar disorder. They've also talked about tardive Parkinsonism for these patients that have Parkinsonism, supposedly drug-induced, that developed early on in this course when they were given or started on a strong D2 blocker, and then you stop the drug, right? Because you recognize that this is probably possibly drug-induced, and the Parkinsonism persists. And the question is this Parkinson's disease with over the drug-induced Parkinsonism, or is this tardive Parkinsonism over acute or chronic Parkinsonism from drug?
Yeah, I think for the audience, this is just an example where it's really important to see a movement disorder specialist if your presentation is not run-the-mill, things are really complicated. This is an area where even if you put 5 specialists in the room, you'd see us arguing. Many of us would say tardive Parkinsonism is very controversial, and some papers suggest it doesn't truly exist, and we're not going to have that debate in front of you, but
sure.
It's a good example where you really need to have close follow-up with someone who really is a specialist if you have a complicated presentation.
Yeah. And then I've also seen, especially lately, I've seen some cases of vascular Parkinsonism with strategic strokes where the DAT scan was abnormal. Like for instance, just very recently, I got a referral for somebody with hemi-Parkinsonism, acute onset. After he had a heart, he's a young fellow, he had a heart myxoma removed, okay? So this is a tumor in the heart, and very notoriously, this kind of surgery is associated with emboli, a shower of emboli to different parts of your body and brain. And unfortunately, he had a strategic stroke there in the midbrain where the substantia nigra is. That's the part of the midbrain, or the part of the brainstem that is involved in Parkinson's. He had an acute onset of Parkinson's syndrome, hemi-Parkinsonism. And I wasn't really sure. I said, I'm almost certain this was stroke related. And I thought the DAT scan was going to help me. And so, and what I saw in the DAT scan though was the DAT scan in the side that was involved in the stroke was abnormal. So this was
the cells are damaged. Even if it's the body of the cell that's damaged, the nerve endings die back too. I've only seen this once in my career as well. So I said earlier, vascular Parkinsonism doesn't usually respond to levodopa. But I had one patient when I was still in training as a fellow. The MRI showed a stroke in the substantia nigra where the dopamine cells are, and that person was responding well to levodopa. So it's a good example where, vascular Parkinsonism doesn't usually respond to levodopa, except if you have a stroke in your dopamine-producing part of your brain.
Yeah. Now, in your experience of this atypical Parkinsonian syndromes, which one, especially in the early stages, let's say the first couple of years, has the highest chance of mimicking Parkinson's disease that even you, a very experienced movement specialist, can possibly be fooled?
Yeah, there's a Parkinsonian variant of progressive supranuclear palsy. And that's a condition, it's actually the second most common neurodegenerative disease after the Lewy body disorders, when you consider Parkinson's and dementia with Lewy bodies as one umbrella condition. And the brain bank studies, especially out of England, the United Kingdom brain bank, show that many people don't have any of the other features till more than 3 years after their other symptoms develop. It can take 5 years or more. So in the Parkinsonian variant, people can even have the acting out of dreams that make us think about Parkinson's or multiple system atrophy.
Sure.
So the Parkinsonian variant of PSP by far is most likely to throw us off.
Yeah, and I just want to add to that the Parkinsonian variant of MSA. So you touched on this, multiple system atrophy having, the Parkinsonism phenotype versus the cerebellar type, MSAC versus MSAP. And I've seen patients with MSAP that present very similarly to Parkinson's. They can be levodopa responsive in the beginning. In fact, there was at least one paper I've read, if not a couple of papers by now, over years, where patients with MSAP actually made it to deep brain stimulation because the movement specialist swore that this patient had Parkinson's disease, maybe even tremor predominant Parkinson's, and that deep brain stimulation was the only option, given that the levodopa wasn't very, very effective.
Yeah, it's very complicated, and unfortunately, we don't have a definitive test to tell us for sure how things are going to look years down the road, because over time, people are more likely to have symptoms that fit with one of these conditions. But in the very first 3 years, it can be really challenging.
Absolutely. And in fact, there was one of my favorite papers to quote is that Mayo Clinic paper, which was published, I think, in 2015, where they looked at the pathologies of the brains of patients that were diagnosed with Parkinson's disease. And they found out that even among movement specialists, the rate of misdiagnosis within the first 5 years is somewhere in the range of about 42%, especially in patients where levodopa, a good levodopa trial has not been instituted for one reason or another, whether it be poor tolerance or just patient is just not severe enough.
That's true. Yeah, one of those papers from right here in Sun City. Yeah,
I know, right?
yeah, yeah. So that, yeah, early on, the accuracy is not as good as once we followed someone for more than 5 years and continue to see response to levodopa. I agree.
And then for your MSA patients, the MIBG scan is actually available locally now. It's being done. The MIBG scintigraphy is actually available in different radiology places. I've actually done a few patients that I had difficulty differentiating between Parkinson's disease with autonomic dysfunction, just prominent dysautonomia versus is this really early mild multiple system atrophy. And to me, that's where the conundrum very often lies, just differentiating these two conditions first, especially when the condition is not fully developed yet. And most conditions can have abnormal DAT scans. Both conditions can have some levodopa responsiveness, or even worse, if they're not getting bad enough to have a levodopa channel, it's really difficult to differentiate one from the other. And then if you do an alpha-synuclein skin biopsy on these patients, given that they're both synucleinopathies, the alpha-synuclein skin biopsy is really not very helpful. And that's where I think the MIBG scan can be helpful. The papers have shown that the MIBG scan is abnormal even in early Parkinson's disease, and in general is normal in multiple system atrophy.
For the audience, it's kind of like a DAT scan except for the heart, and it shows loss of the nerve endings to the heart that release the noradrenaline. That's kind of like dopamine, but helps your body react to the change in position when you stand up, so your blood pressure doesn't drop. And it does seem to be reduced. The nerve endings to the heart for the sympathetic nervous system are really damaged and die back in people with the Lewy body conditions like Parkinson's and also dementia with Lewy bodies. The problem is the scan is not formally FDA approved in the United States to differentiate these conditions. So it's a very expensive test. And also we don't have people that are trained to interpret it. I don't think I feel comfortable interpreting it. But I think if we could get to that point where there were people trained to interpret and there were a way to get it covered, then it could be a useful test. It is actually on the guidelines for diagnosis of dementia with Lewy bodies, but with the asterisk not yet formally available in the US, not FDA approved in the US.
Not FDA approved, yeah. And then you talked about levodopa responsiveness or lack of, or non-durable effect of levodopa for this atypical Parkinsonism. So I guess my first question is, how much do you push that dose of levodopa before you say, okay, patient is not levodopa responsive? Or the other question is, if they are levodopa responsive, how long should you wait before you can say, yep, this patient is out of the woods, definitely levodopa responsive, definitely has Parkinson's disease?
Yeah, I don't think there's a consensus on that. And there are some doctors who are very aggressive in all patients, but the important thing is it's case by case, because in someone who looks like they likely have Parkinson's, but they're just not responding at a moderately high dose, like 600 milligrams total a day of levodopa. If I keep pushing the dose, I really increase the chance they're going to have complications of levodopa therapy, especially dyskinesia. Mm-hmm. So I may use a combination therapy approach if I still suspect Parkinson's. On the other hand, if someone has that corticobasal syndrome where one side of the body seems to be forgetting how to do things, we call it apraxia, there's a funny posture to the hand, and it's painful spasms, and there's no improvement as we get to 600 milligrams a day, but it's making people really sick. If I'm really suspecting the corticobasal syndrome, I won't necessarily push really high because it doesn't work for most corticobasal syndrome patients, and they just have a lot of side effects and they lose weight because they can't eat. However, if I suspect PSP or multiple system atrophy, and I'm seeing slowness of movement in the hands or gait freezing problems that I feel could respond and improve the quality of life of that person, because it could improve muscle stiffness, it can improve fine motor skills or gait freezing, I may push as high as 1,200 milligrams a day with PSP or MSA. So it's really case by case, and also based on getting the whole story and deciding which condition am I thinking is likely present. And I think that's the difference when you see a general neurologist that's not comfortable or experienced enough to use all the diagnostic criteria, or they just don't have the time to get the whole story. They're not going to think along those lines. And that's where the atypical Parkinsonism is a very good reason to refer out, even if they're very comfortable with run-of-the-mill Parkinson's.
And there's, of those atypical Parkinsonian syndromes, you mentioned dementia with Lewy bodies as being notorious for having cognitive issues and dementia even early on. But do these other atypical Parkinsonian syndromes, are they also associated with earlier dementia compared to Parkinson's?
PSP, progressive supranuclear palsy, is associated with an early frontotemporal type dementia, but it's a very different type dementia where you have problems with language or changes in behavior, becoming more impulsive. But very different kind of problems than we would see with the other types of dementia. You don't usually see severe memory loss with PSP. And if you do, and it responds to medications that usually help with memory loss in Lewy body dementia, that would suggest it's not PSP. The other thing is with MSA, it can cause dementia late in the course, but it only causes dementia in 7% overall, and about 40% have mild cognitive impairment, but it should not cause early severe dementia. So you bring up an important question. If someone has severe orthostatic hypotension, but they also have dementia, the most common misdiagnosis I see from my colleagues, where I'm really glad they referred, is the patient has dementia with Lewy bodies, not multiple system atrophy, but they're calling it multiple system atrophy because of that orthostatic hypotension, low blood pressure standing up. But if they already have dementia and they have the other features like hallucinations, that is not MSA, that is dementia with Lewy bodies.
Yeah, I just want to add a caveat to that, in that I myself have been fooled in a patient that later on had floridly obvious dementia with Lewy bodies. In the early stages, I actually sent her to a neuropsychologist when I suspected early dementia with Lewy, hallucinating, autonomic dysfunction, orthostasis, and so on and so forth, and Parkinsonism, which is asymmetric, somewhat levodopa responsive. And then the neuropsychologist said, nope, patient is not demented, so it can't be dementia with Lewy bodies, right? And so we were beating around the bush for about a year or so. That scan was abnormal. So again, that doesn't help me in terms of differentiating Parkinson's from dementia with Lewy bodies. And then only about a year after, when I said this has to be dementia with Lewy bodies, because patient now is much more demented, at least at home and clinically she was, and the rapid onset of the dementia over a year, or progression, I should say, over a year. And the increased hallucinations as I increase the dose of levodopa. So I guess in the early stages, when dementia with Lewy bodies presents to your office, in the very early stages, sometimes it's not very obvious.
Yeah, very tricky, because the definition of dementia varies depending on what your previous function was. So for somebody who is an engineer, they have a very high kind of baseline, and so for them to decline to where we call it dementia, it may take a lot longer. So it's somewhat of a interpretation we call subjective in medicalese, that based on kind of what each neuropsychologist is saying based on their opinion, if this fits or not. But also, is it interfering with everyday activities? And some people have much more complicated everyday activities, more room to interfere than others. But yes, I agree. That is a really important pitfall. And unfortunately, dementia with Lewy bodies is the second most common neurodegenerative cause of dementia, and it's a lot more common than we realize. So the diagnosis can be missed early on. And that's where I would point out that the neuropsychological testing is another piece of information, but that information then needs to be put together with the whole story by an experienced neurologist who sees these things and has time to be fooled early in their career and then learn from their experience.
No, absolutely. One thing that's even more confusing is I've had patients with Parkinson's and Alzheimer's disease, almost concurrent, because these are two neurodegenerative disorders that can develop as you get older, right? And I've had some patients who I thought had dementia with Lewy bodies, and I ask for a neuropsychological test. I also asked for a neuroquant, which is quantification of the volumes of the temporal lobes for the audience, especially the medial part of the temporal lobes, which usually atrophies early in Alzheimer's disease. And I've seen a couple of these patients in my practice now that were diagnosed at least I thought had Parkinson's disease with Alzheimer's, when in fact they presented early on with a picture that is very similar to dementia with Lewy bodies. Although I'd have to say though, I don't think hallucination was a prominent issue in these patients.
Yeah, and something we're learning now because of these brain banks like we have here in Arizona is for people with Parkinson's who have dementia, about half or more of them also have Alzheimer's disease in our brain bank. And people who have dementia with Lewy bodies, the majority, almost 80%, at least in our brain bank, maybe more, have both Alzheimer's disease and dementia with Lewy bodies. So the rule is combination. It's actually the combination, not the exception. It's actually the rule to have more than one problem. So it's very common to see both. And when someone starts with Alzheimer's but also has dementia with Lewy bodies, the Alzheimer's may mask some of the dementia with Lewy bodies symptoms. So we're still working hard to find better ways to diagnose those people, because the symptoms may not be as obvious if you start with a lot of Alzheimer's, but also have dementia with Lewy bodies.
Yeah. And then the other very tricky set of patients to take care of, especially in trying to differentiate Parkinson's from the atypicals, is patients that present to your office with freezing of gait, especially in the early stages of their Parkinsonian syndrome. So do you have any tricks to share with us on how you differentiate, Parkinson's disease from these atypicals when the initial and most prominent symptom is freezing of gait?
Yeah, so there is a subtype of progressive supranuclear palsy, PSP, that starts mainly with gait freezing. They have all these different acronyms like PAG, pure akinesia, and gait freezing. And what I've seen, I've only seen this a couple times in my career, but what I showed on the MRI earlier, there are things we look for there with the shrinking in the midbrain, actually in the midbrain. Also, we don't just look at whether you can look all the way up and then all the way down. And yes, we can still do it on telemedicine somewhat. But we're also looking at, if you look right at the camera, then look down at the floor, then back to the camera, back and forth. We're looking at the speed that you can move your eyes between two targets, the saccade speed. And if the vertical saccades are slowed and the person has early severe gait freezing, chances are this is going to turn out to be that variant of PSP, which fortunately progresses more slowly. But early on, those may be the only features. We may also see some subtle Parkinsonism as well. But early severe gait freezing is a big red flag that it may not be Parkinson's. However, if the person still has other features, like one side is worse than the other, they have the slowness, stiffness, rest, especially if they have rest tremor. But if they don't have rest tremor, but they still have slowness, stiffness, and everything responds well to levodopa, that's still reassuring that the gait freezing was actually due to that slowness of movement, the bradykinesia. So it's really the whole big picture, getting the whole story, doing a thorough exam. But yes, they don't necessarily have to have the severe balance problems for it to turn out to be PSP if there's early severe gait freezing.
And would a trial of levodopa help you differentiate one from the other?
It depends how we're measuring things. It really depends on the whole picture. So, it's something where you can't just have a general neurologist that, is certified in epilepsy saying, okay, I'll give you a trial of levodopa, and if you respond, you don't have Parkinson's. No, we have to look at the whole big picture. Okay. Also, we need to think about, well, if it's just gait freezing, just trouble walking and nothing else, we need to look at the MRI scan, because like I showed earlier, it could be one of those other types, the vascular or the NPH.
So aside from looking at the sizes of the ventricles and the CSF tap test, do you do any other tests for NPH?
Yeah, I mean, the important pitfall with NPH is the gait problem needs to be present. And so that's the most important thing, is looking at the gait. If someone does not have a dramatic response to their tap test, you know, we do the spinal tap, we do the timed walk, but everything else fits. We really look carefully at the MRI, we review it with colleagues, everyone agrees this isn't just due to shrinkage actually in the brain, the ventricles are enlarged. They also have the other features, so we get the whole story. They do have some mild cognitive impairment problems and bladder urgency. If everything fits, just failure to respond to the spinal tap tests alone doesn't necessarily mean it's not going to respond to a shunt. And I will refer them to consider what's called extended lumbar drainage, where we do 72-hour drainage. Yeah. And the neurosurgeon has to arrange that. And before COVID, we could do it in the hospital. For now, we're holding off on that until everyone's gotten vaccinated.
Absolutely. You know, I've also seen a number of patients with NPH in my practice. I sent them over for BP shunting, and some of them have let's say a 50% response, and they're still left up with some gait impairment. Or I have some patients that initially responded very well. Then I follow them up every 6 to 12 months, and then down the road they develop more Parkinsonism, and I have this shunt checked out, and the shunt is still working. So the question is, you know, what happened, right? Why is there gait impairment coming back? NPH is supposed to be one of the reversible causes of lower body Parkinson's, and it's supposed to fix it permanently as long as the shunt doesn't malfunction. So believe it or not, I've actually done DAT scans on some of these patients with apparent pure NPH in the beginning, or that did not respond night and day from the shunt, and I'd say a good 5%, if not almost 10% of these patients have an abnormal DAT scan, and therefore they have, you know, kind of two disorders, NPH is Parkinson's. And the way I prove that is I give them levodopa. And if I'm able to, you know, improve the gait, you know, with that levodopa together with the shunt, which I confirm is working, then I kind of say, okay, this must be two disorders, NPH is Parkinson's. Yeah,
I've definitely seen people that have both, and I've seen people that get shunted even though we weren't, you know, they weren't sure whether the response to the tap was robust. But as things evolve, it's either Parkinson's disease or more often one of the atypical Parkinsonisms, unfortunately.
Yeah. Here's one question from the audience. How often do you see concurrent MSA and Lewy body disease?
So the problem is, in order to diagnose that, you'd have to have, you know, the person donate their brain for an autopsy. There's no way to say for certain that they have both. You need that definitive diagnosis. And there may be reports out there. You know, if you search PubMed, you may find a couple, but I haven't personally seen that reported in our brain bank. And I think we've had, you know, we don't have very many patients that turn out to have MSA in our brain bank to begin with, but over, I think, 1,600 brains donated here over the last 30 years, and I don't think any have had that combination. But, you know, it may be out there, but more often, you know, how often do I see DLB, dementia with Lewy bodies, misdiagnosed as MSA all the time?
Yeah, absolutely.
And I was guilty of that early in my career, more often than I am now, but it still happens to me.
Yeah, but as you said, you know, most MSA patients develop, you know, dementia really late down the road, and only a small fraction of them get floridly demented.
Yeah, but unfortunately, many doctors don't seem to understand that if someone has dementia with Lewy bodies and then they develop that low blood pressure standing up, that doesn't mean they now have MSA.
Yeah. What's more confusing though is MSA patient who develops Alzheimer's disease, because that can mimic dementia with Lewy bodies.
Well, unless it's been confirmed with an autopsy, if they have that presentation, I wouldn't necessarily believe you that they have Alzheimer's with MSA. I still think dementia with Lewy bodies.
Yeah.
You know, we're looking for, when you hear hoofbeats, you think horses, and DLB is definitely the horse when it comes to that presentation.
I guess the caveat is still to simplify the diagnosis. If you can explain everything with one diagnosis, then so be it. But if the picture really doesn't fit with just one diagnosis, then you're kind of forced to make more than one, and rarely even more than two, but very rarely. Okay, hey, thanks so much, David, for this exchange. I really learned a lot from your talk, and I think the audience really learned a lot as well and enjoyed your talk.
Yeah, thank you for having me.
Okay, thank you. And so I'm gonna we're running out of time. I'm gonna turn back the floor